What is revolutionary about cancer immunotherapy is that it targets not the cancer cells but the immune system. By inhibiting a single negative receptor that hinders the activation of anti-tumor T cells, there are patients that show responses even at the advanced metastatic stage with regression of some of all of the tumors. Most importantly, these responses tend to be durable, in some patients lasting several years. My laboratory has been interested for a long time in using radiation to engage the tumor with the immune system. So we showed that radiation would induce anti-tumor T cells when combined with anti-CTLA-4 in a model that otherwise did not respond to anti-CTLA-4. And what is important is that these responses were not only effective in leading to complete rejection of the irradiated tumor, but also led to rejection of systemic metastasis outside of the radiation field. It is still unclear how to best leverage the use of radiation to enhance responses to immunotherapy. We have recently identified a mechanism that links the DNA damage response elicited by radiation to the activation of pathways that are involved in sensing viral infections. So we can say that radiation really can make the tumor look to the immune system as if the cells were viral infected. And this makes a lot of sense because CD8 T cells really developed to protect us against pathogens that gain access to the cytoplasm of the cells. But there is a twist. Self-DNA can also gain access to the cytoplasm of the cells under different circumstances. So cells have developed a mechanism to prevent improper activation of type 1 interferon in autoimmunity. There is an enzyme called TREX1 which clears cytoplasmic DNA from normal cells, and what we found is that it can be upregulated by radiation. What is critical is the radiation dose. When the dose goes above these levels, there is a upregulation of TREX1, which then digests the cytoplasmic DNA and leads to abrogation of the response, silencing this immune response. So these data are especially intriguing because they place radiation-induced DNA damage at the crossroad between viral infection and autoimmunity. They also open an entirely novel understanding of the consequences of radiation-induced DNA damage. In questions, they also open new questions about the effects of radiosensitizer and the role of different mutation in DNA repair genes and how they might influence the immunogenicity of radiotherapy. Most importantly, we can start analyzing the ability of radiation to induce type 1 interferon versus TREX1 in patients to sort of explore this as biomarkers that will enable tailoring radiation therapy to patients in order to increase actually the synergy between radiation and immunotherapy in the clinic. I believe that this is the first step really to improve the use of radiation as a tool to really lead to improvement in cancer care and as a completely new role for radiation therapy in cancer treatment. So this is a very exciting time for radiation sciences.